a todos los presentes en esta sesión. Les recordamos que para poder obtener su constancia de asistencia, deberán colocar su nombre completo y correo electrónico en el chat de Zoom o en el chat de YouTube. Agradecemos de su atención.
Hola, muy buenas noches y sean bienvenidos y bienvenidas a esta última sesión extraordinaria del Colegio Mexicano de Reumatología. Es para mí, el doctor Alberto Chapela, gerente médico de reumatología de Abbvie, darles la bienvenida a esta sesión. Y no por ser la última, la menos importante, queremos cerrar con broche de oro. El día de hoy tenemos el honor de presentarles al doctor Walter Maximovich, quien es profesor, científico clínico y líder médico de la División de Reumatología en la Universidad de Alberta en Edmonton, Canadá. Además, él es miembro del Colegio Canadiense, así como del miembro del Colegio de Medicina Interna de Canadá y certificado en Medicina Interna y Reumatología. El doctor Maximovich es miembro fundador de Care Arthritis, un centro clínico y de investigación dedicado al desarrollo de estrategias personalizadas para diagnóstico y tratamiento de pacientes con artritis. Su foco principal de interés es la imagen y el tratamiento de la espondiloartritis, artritis psoriásica, artritis reumatoide y de la osteoartritis. No por menos ha sido miembro y ha sido autor de más de 500 artículos científicos, capítulos de libros y varios abstracts presentados en congresos, además de ser publicados en las revistas indizadas más relevantes a nivel internacional en el campo del conocimiento. Es reconocido como un miembro académico distinguido y speaker internacional, así también haber sido uno de los desarrolladores más importantes del Consorcio para la Investigación en Espondiloartritis en Canadá, mejor conocido como SPARC, y su sistema de estadificación y clasificación en resonancia magnética para la inflamación estructural y daño en las articulaciones sacroiliacas y la columna, de los cuales ya hemos sido familiares varios de nosotros. Asimismo, también fue coinventor del biomarcador 14,3 beta, el cual está licenciado para el diagnóstico en pruebas en pacientes con artritis reumatoide. Para concluir, el doctor es miembro del Consorcio de Valoración de la Espondiloartritis a nivel internacional, o ASAS, así también mismo miembro de Sparta, y ha sido reconocido como uno de los investigadores más importantes también dentro del protocolo CLASSIC, que es la cohorte de incepción de clasificación en artritis y espondiloartritis axial. Sin más con esto, quiero dar la introducción y bienvenida a nuestro ponente. El día de hoy esta sesión será completamente en inglés y vamos a concluir con una ronda de preguntas y respuestas en vivo con nuestro invitado. Esperamos que vayan compartiendo sus preguntas en el chat. Asimismo, también le haremos algunas de relevancia para este tema tan trascendente en los últimos meses que se ha discutido en reumatología. Bienvenido, doctor Walter.
Hello, everyone. It's my great pleasure and privilege to have this opportunity to present novel developments in classification criteria for axial spondyloarthritis. And I'm very grateful to Abbvie for inviting me to give this presentation. Just like to start off by pointing out some learning materials that I think may be helpful to you, specifically the Care Arthritis app, which you can see is available in Spanish, as well as the Care Arthritis website. These are my disclosures, and this is a specific disclosure from Abbvie and further statements from Abbvie. These are the learning objectives, and specifically we'll discuss new directions in the classification of axial spondyloarthritis that have been generated by the classic study. And I will also discuss advances in the imaging of spondyloarthritis that will be highly relevant to classification. And finally, I want to put these developments into the context of the application of classification criteria for patients in Latin America. So you'll all be familiar with this slide, which nicely summarizes the progression of axial spondyloarthritis. And we've known now for at least the last 2 decades that the disease begins with a non-radiographic stage before progressing to radiographic sacroiliitis and then the development of ankylosis in the spine. And in 2009, we wanted to develop classification criteria that would capture both the non-radiographic and the radiographic phases of the disease. And so the 2009 classification criteria for the first time incorporated MRI assessment of sacroiliitis in the imaging arm so that we could identify patients who were non-radiographic but already had inflammatory features on MRI. And in addition to this imaging arm, there was a clinical arm which required the presence of B27 and at least 2 of the following SBA features. And you can see that the sensitivity and specificity was around 83-84% for the performance of these criteria when compared to the gold standard rheumatologist diagnosis of axial spondyloarthritis. Now, these criteria elicited immediate critiques because of their inappropriate use as diagnostic criteria. We have to recognize in the real world that this is what often happens, that people really don't understand the difference between diagnostic criteria and classification criteria. And then there were some who considered that the criteria were too lenient, were too easy to meet, and that there might be then an explosion of numbers of people who might have a diagnosis of non-radiographic axial SPA. And then there were some concerns raised that genetic studies of patients who were selected using these criteria demonstrated a lack of association with certain genes that had been associated with ankylosing spondylitis in patients selected using the modified New York criteria. And there was also some concern that the criteria relied too much on imaging and HLA-B27. And here's some examples of the concerns raised by the application of the criteria for the purposes of diagnostic ascertainment. We see in this survey of patients in the United States that when the criteria were applied, the estimated prevalence was almost 0.7%. But 24% of these patients did not even have a diagnosis of axial spondyloarthritis. And then there were surveys of patients from the Netherlands which assessed the prevalence of axial spondyloarthritis in primary care patients with chronic low back pain. And again, a high prevalence of 24% of patients were identified with axial spondyloarthritis when these classification criteria were used for the purposes of identifying patients with a diagnosis. And so these concerns that I've outlined led the FDA to express concerns around the misdiagnosis of non-radiographic axial spondyloarthritis in particular, and potential for inappropriate prescribing of biologics. So the FDA was concerned that there would be false positive diagnoses if these classification criteria were used for diagnostic evaluation. And the FDA then required that these patients be selected according to either an elevated CRP or a positive MRI for sacroiliitis in trials of non-radiographic axial SPA. And also there was a requirement for a 52-week placebo period. And so for some time, clinical trials of non-radiographic SPA were designed with these selection criteria and with this particular study design. And so because of these concerns, the ASAS and Spartan professional societies decided it was time to test the performance of the 2009 criteria, and to do this globally, and in particular to include North America, which had largely been excluded from the assessment in 2009 when the classification criteria were developed. And this is the study which we call CLASSIC, the classification of axial SPA inception cohort study, which was conducted between 2019 and 2022. And there are a great many people, as you can see by the 60 authors that are included in the title slide of the presentation that I gave at the ACR in Chicago this year. And these were the CLASSIC study objectives. So firstly, the aim was to validate the performance of the 2009 criteria in a prospective cohort of patients who had undiagnosed current back pain of at least 3 months duration and with an onset of that back pain at less than 45 years of age. And we were really aiming for performance of 90% for specificity and 75% for sensitivity. And if these criteria were met, then we would consider the performance of the 2009 criteria as adequate. And if these criteria did not meet these performance targets, then we would revise the criteria to achieve these sensitivity and specificity performance criteria. We were particularly interested in high specificity, and this is because we of course wanted to avoid false positives when applying the criteria. And so here are the inclusion criteria. As I stated, the exclusion criteria were really aimed at excluding patients with recent trauma, as this could compromise the clinical evaluation of patients and which clinical features might be important to diagnostic decision making. And we of course did not want to include patients who already had the diagnosis of spondyloarthritis. We also wanted to make sure that these patients were able to undergo MRI assessment. We wanted all patients to undergo MRI assessment, as this is increasingly a major diagnostic tool. And so if for whatever reason, such as metallic fragments or a pacemaker, if for whatever reason these patients could not have an MRI, they would be excluded. And this is the study design summarized on this slide. And so a series of diagnostic assessments were performed. First of all, after the history and the physical. And rheumatologists were asked to indicate if they thought the patient had a diagnosis of axial spondyloarthritis, yes or no, and a level of confidence from -5 to +5, -5 being definitely not Abbvie and +5 being definite Abbvie. So this was done after the clinical assessment. It was then repeated after the laboratory investigations were available, and again after the results of the pelvic radiograph were available, then again after local MRI assessment was available to the rheumatologist, and then finally after central readers had reviewed all the imaging and the results of that assessment had been provided to the rheumatologist to make the final gold standard diagnostic evaluation. And at that time, the rheumatologist was asked to respond to the question, is the patient's clinical, radiographic, and MRI presentation consistent with a diagnosis of Abbvie? And this is what the question looked like. Here's the question again here. The rheumatologist would answer yes or no. And here's a confidence scale from -5, indicating definitely not Abbvie, to +5, indicating definitely Abbvie. And 1,015 patients were recruited from around the world. And you can see that there were 51 patients recruited from Mexico to the North American portion of the study. In total, 61 centers from 27 countries participated from around the globe. And I'm going to first of all present the descriptive data. So we can see here that 370 patients, or 36.4%, were diagnosed according to that final stage 5 global assessment. They were diagnosed with axial spondyloarthritis. And you can see here majority of those diagnosed with axial spondyloarthritis were males, almost 56%. You can see that the age at diagnosis was 35 years. And you can see the long symptom duration of 9 to 10 years of these patients before presentation to a rheumatologist. Then we see that the majority had inflammatory back pain, whether it's the investigator opinion or the ASAS definition of inflammatory back pain. But note that a majority of those with non-Abbvie also had inflammatory back pain. So this is not a particularly strong discriminator between those with and without axial spondyloarthritis. When we look at peripheral inflammation, we can see more patients with Abbvie had peripheral arthritis, but actually more patients with non-Abbvie had tender joints. Heel enthesitis was also more common in those without Abbvie. Very few patients had dactylitis. For extra musculoskeletal manifestations, we see more acute anterior uveitis in those with Abbvie, but somewhat more psoriasis in those without Abbvie, and somewhat more colitis in those with Abbvie. You can see that family history and mobility were not helpful in discriminating between these two patient populations. When we look at MRI features, we see that MRI indicative of AxSpA, and I'll discuss this more in detail shortly. So this is a global assessment, whether the MRI indicates AxSpA or not. And you can see, according to local reader assessment, about 82% compared to 62% by central readers. There's a certain degree of overcall by local readers. We look at active lesions, 60% were positive for active lesions by local readers, but only 48% by central readers. And we can see that more patients, in fact, 68%, had structural lesions than active lesions, and this is the same for central reader assessments. So when patients present to a rheumatologist, structural lesions are already frequent and more frequent than active inflammatory lesions. And so this is an important point to bear in mind. And also, if you rely on the ASAS definition of a positive MRI, which is focused only on bone marrow edema, this failed to detect 59 or 20, almost 26% of the 228 cases that were positive for an MRI indicative of AxSpA. This is really reflecting that it's not that unusual for patients to present only with structural lesions. I forgot to mention that CRP was elevated in about 40% of patients with AxSpA, so that's not particularly sensitive, and B27 was present in 67% of patients with AxSpA. Now, how did the 2009 criteria perform against the stage 5 diagnostic assessment? So when we look at central reader imaging data, you can see that the sensitivity was almost 74%, the specificity was 84%. So the criteria of 2009 failed to achieve 75-90 performance targets for sensitivity and specificity. When we look at local reader data, the sensitivity is somewhat higher at 83%, but the specificity is lower at 77%. So it doesn't matter if you look at central reader data, local reader imaging data, doesn't matter how the imaging is assessed. The 2009 criteria failed to achieve those 75% for sensitivity, 90% specificity performance targets that were required. And so we then proceeded to revise the criteria, and we proceeded to test various models that we thought would improve the criteria and generate better performance. We tested these models in half of the data set, which we call the testing data set. The other half was used for validation purposes, and we took our best performing models from the testing data set and tested them in the validation data set. We also used the MRI variable, MRI indicative of SPA, which, as I mentioned previously, combines information from all MRI sequences that assess active and structural lesions, because this is a much more sensitive indicator of a positive MRI. We also decided that imaging alone would not be sufficient for fulfillment of the criteria. And we also decided that if a patient was imaging negative and B27 negative, that they could not be classified as AxSpA. And then we aimed to achieve, with our revised criteria, sensitivity of 75% and specificity of 90%. And we used this technique in addition to other techniques, but this is a technique that's been used extensively, and it's a form of regression analysis that has been used extensively since about 2010 in the generation of classification criteria by ACR-EULAR. And what does Lasso enable you to do? So it first of all assesses the data and establishes which SPA variables are independently associated with the diagnosis of axial spondyloarthritis. This tells you something about which are the important SPA variables that drive clinician diagnostic decision making. Secondly, it also determines how each of these SPA variables should be weighted. So we all know that we consider some SPA variables, for example, MRI, more important than other SPA variables. They cannot be weighted equally. Now, MRI is more important than heel enthesitis. And so the Lasso regression coefficients tell us how these SPA variables should be weighted. And then what you do after these first two steps is you sum up the weights for the selected SPA variables to give you a total score. And then once you have that total score, then you have to decide, okay, what's the cutoff that I'm going to use, above which I say that if a patient has a higher score than the cutoff, then we classify the patient as having axial spondyloarthritis. And of course, we want the cutoff to be chosen so that we get as close as possible to our predefined target of 75% sensitivity and 90% specificity. So let me show you how that works with this example of the giant cell arteritis criteria. So these criteria, first of all, stipulate that they should be applied to patients who already have the diagnosis of giant cell arteritis, and where other mimics that resemble giant cell arteritis have been excluded. And you see here a table with variables that are very relevant to the diagnosis of giant cell arteritis. And these are both clinical variables, laboratory, imaging, and biopsy variables. And you won't be surprised when you see that a positive temporal artery biopsy has the highest weighting, a score of 5, and the other variables have a lower weighting than a positive temporal artery biopsy. And you can see that for these criteria, you sum the scores for the 10 items here. And a score of over 6 points is needed to classify the patient as having giant cell arteritis. And when you apply that cutoff, then you get a sensitivity, the best combination of sensitivity of 87% and specificity of almost 95%. So this is what we call a table format with a cutoff over which the patient is classified as having the disease. And so this is just a list of classification criteria developed by ACR-EULAR since 2010, starting off with the RA criteria. And they've all applied a similar table format and applied weights to the different variables to reflect their importance to clinician diagnostic decision making. And you sum up the score for the positive variables, and then you see if the patient has the cutoff or a higher score than the cutoff to be classified with these different diseases. And you can see that in 2004, the juvenile spondyloarthritis criteria were designed in exactly the same way. And this is a very important statement from the ACR and EULAR that there have been major methodological advances in the derivation of classification criteria, and that there has been movement towards weighted criteria with threshold scores. And that's because weighted criteria improve the measurement properties of classification criteria, which may then be more discriminating. And so we wanted to make sure that the AXPAR criteria were current, were consistent with current recommendations for development of classification criteria. And this is just an example of the weighting for the imaging component of the classification criteria for juvenile spondyloarthritis. You can see that unequivocal sacroiliitis gets a score of 10, whilst MRI gets a score of 23. And that's not surprising because MRI is a more precise imaging technique and gives more information than a radiograph. So what did the Lasseau regression look like when we analysed the classic data? And here are the results with the variables that were selected. And not surprisingly, MRI had the highest weighting with a high Lasseau coefficient. Inflammatory back pain, according to Clinician Global, B27, inflammatory bowel disease, radiographic sacroiliitis, and heel enthesitis were selected. And this is the table indicating the selected variables and the importance, the contribution of each variable to the diagnosis in the form of these Lasseau coefficients. If you use multivariable regression, you get a rather similar result. Now, this is a statistical technique that's not quite as sophisticated as Lasseau regression. But many of us are familiar with multivariable regression and more familiar than with Lasseau regression. But you can see by the odds ratios that we get a very similar selection of variables, exactly the same variables: MRI, radiographic sacroiliitis, inflammatory back pain, B27, and inflammatory bowel disease, very similar to the Lasseau regression. Now, we were also particularly interested to understand what were the important clinical variables that were selected by the Lasseau regression. And this was because imaging was so dominant in the Lasseau regression, we were concerned that if we did the analysis in the entire data set, that we could miss important clinical variables because imaging variables were so important. So what did we do? We did a Lasseau regression in those patients who were considered to have a diagnosis of AXPAR even though the imaging was negative. And so this was a sub-analysis using Lasseau regression of patients diagnosed with AXPAR whose imaging was negative. And you can see that B27, not surprisingly, was selected, inflammatory back pain, and now peripheral arthritis was selected, as well as dactylitis and acute anterior uveitis. So these were three additional clinical variables that were not selected by the Lasso when the entire data set was analyzed. So here we're only analyzing the data from imaging negative cases. So we generated two models, Model A and Model B, and Model A is directly generated from the Lasso. And you can see here that MRI has the highest weighting of 8, radiographic sacroiliitis has a weighting of 7, B27 has a weighting of 4, inflammatory back pain has a weighting of 3, and the other variables all have a weighting of 1. So this model is directly selected from the Lasso regression that I just showed you. And to be classified, you need to have 11 points. That's the cutoff. So you cannot be classified using imaging alone because MRI is 8, radiography is 7, and you can only use either MRI or radiography. You can't add the two together to get a score, for example, of 15. So you need at least 11 points. You can see if the B27 is negative, an MRI or radiography is negative, when you add these values up, you get to a score of 9. So you cannot classify the patient as being AxSpA positive if the imaging and the B27 are both negative. You only get to 9 points, and that's insufficient because the cutoff is 11 points to be classified with AxSpA. Now, a second model was generated, Model B, and this was largely based on results from the multivariate regression and using that to modify the 2009 criteria. You'll recall in the 2009 criteria that MRI and radiography were weighted equally. And so in this model, each get a weighting of 6. And then certain clinical variables were considered to be more important, such as uveitis, inflammatory bowel disease, peripheral arthritis. These were given a weighting of 2. Now here, the cutoff is 9 points as opposed to 11 points. And here it's important to stipulate that if both imaging and B27 are negative, the patient cannot be classified with AxSpA. It's important to add this footnote because if you add the clinical variables, you get a score of 11. And that would mean that you could classify even if the imaging and the B27 were negative. But we decided that we would not allow that, and so a specific footnote needs to be provided. So now how do these models perform? Here's Model A, and you can see in the testing data set, and we decided that local reader imaging data was most important because in most classification studies, we're not going to have central readers doing the imaging. We're only going to have local readers. And so we need to rely on local reader imaging data. And you can see here that in the testing data set, both models A and B perform very similarly. Model A has somewhat higher sensitivity than Model B by about 6%. Very comparable specificity. Now, the all-important testing is in the validation database, because in this testing database we tested a lot of different models, but we only tested our high priority models in the validation database. And we can see here that with Model A, we reach our performance targets with sensitivity of almost 80% and specificity of 90.4%. Very similar specificity for Model B, but sensitivity is somewhat less. And it was Model A that was selected by a combined vote of ASAS and Spartan. And so these are the 2025 ASAS Spartan revised classification criteria for axial spondyloarthritis. So it's a table format. MRIs weighted higher than radiographic sacroiliitis. This is consistent with face validity, and we require at least 11 points for the patient to be classified as having axial spondyloarthritis. Now, it's important that we're using a different MRI variable that captures both structural and inflammatory lesions. And that's because this variable enhances sensitivity without compromising specificity. And so the ASAS positive MRI definition is no longer adequate. And it's important that a specific protocol for assessment be used. So you'll be familiar with the semicoronal T1 and the semicoronal fluid sensitive stir sequence. So these are required to evaluate the sacroiliac joints. But now we also have an erosion sensitive sequence included. And this, as you can see, gives us better delineation of the cortical bone, and we can more clearly distinguish the surface of the cortical bone for erosions. And a typical sequence would be a 3D gradient echo FATSAT. But in addition, we want an axial orientation to the stir sequence so that we can precisely localize where bone marrow edema is located. So the stir sequence tells us about bone marrow edema. The fat-sensitive T1 tells us about fat metaplasia, erosion, and ankylosis. And the erosion-sensitive sequence is very sensitive for detecting erosion because, as you can see, this is a very important contributor to the MRI appearances in patients presenting with undiagnosed back pain. So the MRI indicative of AXPAR variable is a synthesis of information from all MRI sequences. And this is how the variable has been defined. It's defined as ASAS-defined inflammatory and/or structural lesions assessed simultaneously by contextual review of all recommended sequences by at least one reader with expertise in AXPAR imaging that are highly suggestive of AXPAR in terms of both the location in the sacroiliac joint and their extent. And both types of lesions, rather than one type of lesion alone, will usually be evident. And these are the inflammatory lesions, and these are the structural lesions that are considered when we interpret the MRI scan. And you can get more information about these specific lesions and how to detect them in these manuscripts that are cited here. Why do we want imaging in two planes? So this is the reason. When we look at the fibrocartilaginous portion of the sacroiliac joint, where we typically find bone marrow edema, you see that it's a C-shaped structure. It's more of an L shape in women and more of a C shape in men. And the synovial portion of the joint is in the antero-inferior 1/3, and the anterior portion at the apex of the C is where mechanical stress-related bone marrow edema is located. So when you look back at these at the sacroiliac joint, stress-related BME is seen in anterior slices and at the very anterior portion of the joint. So here, in this patient with stress-related osteoarthritis, or let's say someone who's an athlete, you see here at the very anterior portion of the axial slice is where stress-related BME is observed. And in the future, we will also have more advanced MRI sequences. So it's just emphasizing the importance of MRI as an advanced imaging tool, because in addition to these thin slice high-resolution sequences such as Vibe or Lava Flex, where we get very nice delineation of the cortical surface, we can also generate an MRI image that looks like a CT scan. So this is zero echo time MRI, and you can see it really looks like a CT scan. So it really does make sense to weigh MRI with a higher weighting than radiography. Radiography is really not going to change, whilst MRI keeps getting better and better. So now I'd like to just go over a few examples of cases that might be seen among Latin American patients. So here's a patient who's a 26-year-old female. She's had 1 year of inflammatory back pain, and she had an AAU attack 6 months ago. Her pain is getting worse and she has failed 3 non-steroidals. You can see her BASDI is very high, but nothing to find on physical exam. She's B27 positive and her CRP is normal. So would this patient be classified according to the 2025 criteria? Well, we get 3 points for inflammatory back pain, 1 point for acute anterior uveitis. We get 4 points for B27 positivity. And then the MRI here shows erosion. You can see the widening of the joint space. There's a little bit of bone marrow edema, but there's a bright signal in the erosion cavity. And in fact, if I was to show you DICOM slices, you would see the erosion evident, especially on erosion-sensitive sequences. And you would see the erosion on at least 3 slices. So this MRI is indeed indicative of axial spondyloarthritis, and that gets an 8 points. So the total for that patient would have been 16 points. So that patient would definitely be classified as having axSpA. What about this 25-year-old male with 4 years of inflammatory back pain, has a history of psoriasis, and not really responding to anti-inflammatories? The BASDI is 5.7, has a painful left Achilles. However, the B27 is negative, and we know that B27 negativity is usually the case in patients with axial inflammation and psoriasis. The CRP is normal. Now, would this patient meet the 2025 criteria? So what do we see in this patient? So there are 3 points for inflammatory back pain, 1 point for psoriasis, 1 point for tender Achilles. So that's only 5 points. What about the MRI? Well, there's a region of fat metaplasia. Here's an erosion-sensitive sequence, and we can see there is some erosion here. There's very mild bone marrow edema around the region of the erosion on the axial sequence. So this MRI is indicative of AxSpA. That's 8 points. So we have a total of 13 points. You can see the radiograph looks mostly normal. So between the erosion, a very slight amount of bone marrow edema, but this bone marrow edema is not highly suggestive of spondyloarthritis. But these structural lesions help us to make the decision. This is a classic fat lesion with a distinct border, adjacent to subchondral bone, homogeneous, bright signal on the T1 weighted sequence, and there is a region of erosion. Let's move on to this case of a 36-year-old male with 3 years of inflammatory back pain, failing non-steroidal agents, and this patient has peripheral arthritis. This patient also is B27 negative, and we know that B27 positivity in Latin American patients is not as high as in Caucasians. This patient has a history of AAU and has enthesitis, but not around the heel. So would this patient be classified? Well, this patient has 1 point for the presence of peripheral arthritis. There's 1 point for AAU. Now, the rheumatologist did not think that the pain was that inflammatory and was thought that the characteristics of the back pain had some inflammatory features, but they were mainly mechanical. The rheumatologist was not prepared to say that this was typical of inflammatory back pain. So what do we have for CRP, which is elevated? That's 1 point. We have a total of 3 points. Now here the MRI is crucial because we need the MRI to be positive to get to 11 points. And we can see on the stir sequence that there's very little bone marrow edema, maybe one small region here, but just not sufficient. There are some regions of fat metaplasia, and then the cortical bone is difficult to interpret. Is there some erosion or not? And here on the erosion sensitive sequence, we see there's quite a bit of irregularity of the cortical bone. In fact, even the radiograph does not look positive, and it looks like there is bilateral, at least grade 2, sacroiliitis. So this patient gets 8 points and gets to 11. Finally, one more case here of a 32-year-old female with 2 years of inflammatory back pain, who's B27 negative, normal CRP. Is the MRI indicative of AxSpA? So the CRP is slightly elevated. That should say 1 point. And the MRI was indeed positive, so that's 8 points. And the patient had inflammatory back pain, so that gets the patient to 11 points. And the patient can be classified with axial spondyloarthritis. So in conclusion, the 2025 criteria have much higher specificity than the 2009 criteria. The 2025 criteria require greater emphasis on imaging, but cannot classify using imaging alone. Cases cannot be classified if both imaging and B27 are negative. And here's something that's very important. The correct application of MRI requires adherence to the recommended MRI methodology and assessment of both inflammatory and structural lesions. What are some important gaps? Well, research is already ongoing to identify get more details on what can be considered an MRI indicative of AxSpA. Can we more characterize what constitutes inflammatory back pain? Can we improve on the existing criteria for inflammatory back pain? Is it adequate to just have one reader, or should we always have at least two readers with adjudication for evaluation of radiographs and an MRI? And should we do more than just a physical assessment of heel enthesitis? Should we employ ultrasound? So these could be additional refinements of the 2025 criteria. So I'd just like to thank you for your attention, and the classic research teams in each country, the central imaging reviewers, and then the IT team at Care Arthritis for making the class.
Bien, quiero agradecer la participación en esta presentación del doctor Walter Maximovich. Mientras tanto, y si pudieran, por favor, proyectarme, pero la pantalla completa, la de PowerPoint, estoy viendo ahorita la de respaldo. Agradeceré que pudieran. Exacto, muchísimas gracias. Bien, pues bueno, como pueden ver, este tema es coyuntural, tiene muchísimas complejidades, bastante por discutir todavía, y creo que esto nos va a tener dentro de la discusión en el transcurso del siguiente año y los próximos para poder entender mejor cómo clasificar estos pacientes y sobre todo también entender el desarrollo de los futuros protocolos, ya que en investigación clínica pues se continúa trabajando en el desarrollo de nuevas moléculas en el campo. Yo quiero invitarles, por favor, a que se tomen la oportunidad y el tiempo, a quienes de ustedes estén interesados, vean muchos pacientes con espondiloartritis o que sean también parte cotidiana de su consulta, tener este alcance, ya que Abbvie está convocando para poder llenar una encuesta que nos apoye a entender mejor las prácticas actuales y enfoques en el tratamiento y manejo de sus pacientes con espondiloartritis axial. Asimismo, entender mejor desafíos y barreras que se enfrentan en el diagnóstico y manejo, así como el tratamiento de pacientes con espondiloartritis axial. Para ello, les invito a que escaneen el código QR que pueden ver en la pantalla y vamos a ver si les pueden colocar aquí también un link para la encuesta misma, para quien no puede escanear el QR en este momento, igual a través del chat puedan ingresar a través de este link que se les estaría proporcionando y que nos regalen de 20 a 25 minutos aproximadamente de su tiempo para que puedan participar en esta encuesta y podamos entender mejor e incrementar o mejorar la comprensión en las brechas de estándares de cuidado en pacientes con espondiloartritis. Si podemos pasar a la siguiente, por favor, en lo que... Muy bien, muchas gracias. También para nosotros es muy importante que nos puedan proporcionar una retroalimentación para quien les sea posible escanear este QR también y darnos en esta breve encuesta sus comentarios, un feedback muy rápido, pero que nos sirve a nosotros para poder mejorar en brindarles educación médica continua de calidad. Y mientras tanto, también esperamos a que nuestro ponente pueda estar aquí con nosotros. Doctor Walter, if you hear me, if you're present. Me parece que el doctor ha estado teniendo algunos temas técnicos para poder enlazarse a nuestra parte o ronda de preguntas y respuestas. Igual les invito a que, ya sea en el chat en YouTube o en la sesión en Zoom, puedan compartirnos algunas de sus inquietudes, ya sea que en caso de que nuestro ponente no pueda acompañarnos en este momento o que sigan las complicaciones técnicas, em, pues podamos hacerles llegar algunas dudas particulares. Estaré dando un par de minutos. Mientras tanto, igual si me pueden regresar a la anterior y recordarles, ya está aquí el QR y me hicieron favor de postear el link en Zoom para quienes estén conectados. Les agradeceré nuevamente, nos puedan apoyar ingresando, otorgándonos unos 20 minutos aproximadamente de su tiempo. Algunas de estas preguntas se repiten, pueden hacerlo un poco tedioso, pero es justo para validación de esta encuesta. Lo importante es contar con una muestra de centros de México para que con esto se pueda llevar un análisis y una posterior o potencial publicación, presentación también de algún abstracto en Congreso y pues haya representatividad de México, que ya vieron que es bastante importante en términos incluso de la clasificación en espondiloartritis axial, que espero que les haya dejado no solo inquietudes, sino también resuelto algunas dudas en torno a este tema. Y bien, Dr. Walter, are you here? Are you available to be with us? Bien, me parece que por temas técnicos igual el ponente en este momento ya no pudo acompañarnos, el doctor Walter, pero voy a poner mi correo de todos modos en el chat para quien en caso que tuviera alguna duda puntual, alguna inquietud para acercarse no solo al doctor Walter, sino al grupo Spartan, pues puedan hacernos favor de enviarnos cualquier pregunta que tuvieran, cualquier comentario y hacérselo llegar a él para canalizarles con ustedes. Y bien siendo las 9:05 de la noche, les agradezco mucho su participación en esta sesión, el tiempo que se tomaron para acompañarnos. También desearles de verdad unas muy felices fiestas, que pasen en compañía de sus seres queridos o si ya se van a encontrar trabajando también, que lo hagan de la mejor forma, que cierren este año de forma estupenda y los mejores deseos para este 2026 que tenemos ya casi a la vuelta de la esquina. De verdad, en nombre de Abbvie les agradezco muchísimo su tiempo y su atención y al Colegio Mexicano de Reumatología por todas las prestaciones para poder acompañarles en este evento. Muchísimas gracias.